Dr. Parekh, what is the format? It will be one case per student, or both the students can answer for the same case?
They'll be parallel, ma'am. Parallel.
Okay. Okay.
We are live. Good evening, everyone. Welcome to the 9th episode in the second series of masterclasses brought to you by the Academic Council of IASO. The topic for today is GE junction tumors. I invite one of our advisors from the Academic Council, senior IASO member, Dr. Harit Chaturvedi, to kindly deliver the open address. Sir.
Thank you, Dr. Srijan. And it's my pleasure and privilege to really welcome the students for this IASO Masterclass series, which has become a big hit in the DNB and MCH fraternity, student fraternity. And the reason for that hit is that actually the way engagement happens, there's a lot of learning which happens as you discuss cases, and there's an expert talk by a real expert on the subject, and it integrates the whole thing together. So as we were talking just before this went live, that actually still a lot of students are not able to reach out. So I will urge that each student should make sure that their faculty, their colleagues, their peer group across the country is made aware, and more participation happens. And this is the best way to improve cancer care across our country. This is also the best way to grow professionally, because the more you learn and engage in the community, there is learning and ongoing evolution which happens on both sides. So it's very heartening that this masterclass series has taken off very well. And today's topic, as we know, is one of the most challenging areas, if I can say, for a surgical oncologist. Not that any area is easy or cakewalk, but I would say this is one of the challenging areas where you have to identify whether to treat like esophagus, like stomach, and how do we go around, and the integration of the multimodal approach. The radiation oncology and medical oncology, how we integrate all that. So I think a lot of exchange will happen, and I'm hoping to see that this will lead to better practices even in remote areas and across our country, because these tumor boards or discussions are critical for evolution for all of us. So thank you very much for having me, and I think we have got a fantastic faculty. Dr. Savita is so well known across our country for her work in esophagus, lung, and GE junction tumors, and the remaining faculty, Dr. Suraj, Dr. Devendra Parekh, they are all experts. So I think let us look forward to this next 1.5 hours of treat. Thank you.
Thank you, sir. The examiners for today are, we have Dr. Suraj Pawar, who's the chairman and managing director at Kolhapur Cancer Center. He has done extensive work on carcinoma esophagus, including developing an innovative technique of thoracoscopic surgery, semi-prone position, which is the largest such series in the world. He has more than 25 years of experience. We welcome you, Dr. Suraj Pawar, to the IASO Masterclass. He's being joined by Dr. Sabita Jivnani, who's a professor of thoracic surgery at the Department of Surgical Oncology at TMH Mumbai. She is also the convener of Thoracic Disease Management Group and is a member of the IEC at TMH Mumbai. We welcome you, madam. And the moderator for today would be Dr. Devendra Parekh, who's from Gujarat, Ahmedabad, who's done his MCH from GCRI, and following which has done fellowships at National Cancer Center, Tokyo, as well as done his robotic training at California. The examinees for today, we have Dr. Ved Prakash, who is the resident at Mahavir Cancer Sanstha, Patna, and he's being joined by Dr. Koteshwar Rao Kamalapuram, who's the resident in the Department of Surgical Oncology at the Sir H.N. Reliance Foundation Hospital, Mumbai. A few instructions for the session. The first session is the mock examination, which would be for 60 minutes. For our examinees, we expect you to give to-the-point answers to the questions being asked. No candidate is ever expected to know everything, so there's no harm in mentioning if you don't know something. It saves us time, and it does maintain the flow of this webinar. Our examiners do have the habit of giving hints all the time, so it's up to you to catch one. For our examiners and moderator, there are two students in this webinar. We request you to kindly give both of them equal opportunity to engage. And in interest of the online viewers, we request you to give the expected answers to the questions that remain unanswered or have been incorrectly answered. For our participants, the senior IASO members in the group, thank you for your participation, and we request you to post in your inputs also in the chat box. And for the residents both here as well as on YouTube Live, it's a unique opportunity to clear all your doubts. From my side, I'll be giving a hint to the examiners at 45 minutes on the chat and at the conclusion of the case discussion at 60 minutes. That's all from me. I hand over this virtual mic now to our moderator for today, Dr. Devendra Parekh. You may share your screen, sir. Thank you.
Thank you, Dr. Srijan and IASO team for giving me this opportunity. And I welcome all the examiners and examining students. Topic for today's discussion is GE junction tumors, and we have prepared a couple of cases for the same. Let us start with the discussion. My slide is visible?
Yes, we can see your slide.
Okay. So let us start with case 1. This is a case of 55-year gentleman, well-built, moderately nourished, with complaint of dysphagia to solid for 1 month. And there is a weight loss of 7 kg. His present height and weight is 172 centimeter and 69 kilogram. Performance status is absolutely no complaint. ECOG is 0. General examination is NAD. I would like to invite examiners to ask if there are any questions at this point.
If I'm not mistaken, the examinees are Dr. Ved Prakash and Dr. Koteshwar Rao, correct?
Yes, yes.
So if you see this patient who is complaining of dysphagia, what else would you ask in relation to the dysphagia when this patient comes to your OPD?
I would like to inquire more on the history of presenting illness on dysphagia, like what is the duration is given. So what is the progression, whether it has progressed from solid to semi-solid to liquid. So whether it is progressive dysphagia. Second thing, I would like to know if there is any associated vomiting or not along with dysphagia. Third thing, there could be any recurrent laryngeal nerve palsy symptoms suggestive of hoarseness of voice.
Okay. So what would you ask the patient?
If there is any change in dietary habits, like if he needs to take a liquid along with his solid food intake, whether he has modified his food intake frequency.
And what about, you were talking about the change in voice. So along with the change in voice, if there is a recurrent of involvement, what other symptoms are you likely to see?
Like he would be complaining of cough because of recurrent aspiration.
Okay. And do you think this weight loss is significant?
Yes, ma'am. It is more than 10% and within 1 month. So it is significant weight loss.
So I don't think the duration of weight loss is given, but you have to know what is the definition of weight loss, how much weight loss and how much time to call it significant. Dr.
Yes.
Suraj Pawar, would you like to ask anything in the presenting history?
Am I audible, Savita?
Yeah,
Yes.
we hear you.
See, significant weight loss, duration of time, and I just with Prakash just asked about the history of hoarseness. That is extremely significant history in the hoarseness of voice, whether the recurrent laryngeal nerve is involved or not. That again a pointer to the advancement of the disease. But is there any guidelines about the duration of the weight loss, and in what duration, how much weight loss? Any guidelines there on the Savita? What do you want to speak on that?
I will give that answer. I would like to ask the other candidate, Dr. Koteshwara, would you like to take that question?
Yes, ma'am. I would like to. There is a 5% of weight loss in a 1 month of duration or 10% of weight in a 3 months of duration. We will call it as a significant weight loss.
So usually the accepted definition is 10% of the patient's body weight in 6 months. That is considered
months.
as significant weight loss. Okay, along with dysphagia, weight loss, cough, change in voice, anything else you would like to ask for, Dr. Koteshwar Rao?
Ma'am, I would like to ask any history of regurgitation and any history of uh, heartburn and any history of cough.
Okay, so why is the change in voice and cough so important? Why are we all reiterating that point?
Change in voice and cough mainly because of the recurrent laryngeal nerve involvement, because of the one is tumor as well as the adjacent lymph nodal enlargement.
Right. So how does it change the patient's management? How does it change the patient's staging? What are your options now? What will you do? Why is it so important? The recurrent laryngeal nerve involvement.
Recurrent one is depends in your staging workup. There are number of the nodal station involvement is included as 1 to 3 as a N1 and 3 to 6 is a N2 and more than 6 is a N3. So here number of nodal station involvement is it upgrades the stage of the disease that modifies the treatment protocol.
Also, clinically, if the patient has recurrent laryngeal nerve involvement, the patient is at risk for aspiration.
Recurrent
Right.
aspirations and pneumonia followed by pneumonia.
So if the patient is severely hoarse and if he is aspirating every time he takes liquids, you would advise the patient in the OD not to take orally till you have done a complete evaluation, right?
Yes.
So you would think of putting a feeding tube, a Riles tube or a nasojejunal tube and feed the patient through that to avoid recurrent aspirations.
Okay.
Any other history you would like to ask besides this? So he said long-standing dyspepsia, acid peptic reflux. That is an important history. Anything else you would like to ask? Important history to ask in esophageal cancer is actually backache. So now we don't see such large tumors, but usually because it's a posterior mediastinal organ, it can compress on the nerves, on the vertebrae, and it can cause backache. So that is suggestive of a locally advanced tumor. So backache is also an important history to tell you where the backache is.
Yes.
Okay.
Right. And another thing.
Yes.
Yeah, please.
Go on.
So whenever we elicit the history of backache, we need to ask whether patient is able to sleep at night properly or not, because most of the time patient will have excessive backache at the time of midnight. So he or she will not be able to sleep at night properly. That is one thing we need to ask in advanced cases whenever they talk about, because many a time backache is something which is associated finding and may not be related with cancer. So just to make sure that backache is related with malignancy or it is something else to do with. Okay, so let us go ahead. With dysphagia, whenever patient present, what is the first investigation? Dr. Ved?
Yes, sir. I would ask for upper GI endoscopy, sir, along with biopsy.
Upper GI endoscopy biopsy. And yes, what are your goal for doing upper GI endoscopy? What do you ask your medical gastroenterologist?
I would like to know the extent of lesion, if there are any, proximal extent, distal extent, the associated Barrett esophagus, if there is any, the thickness of the, thickness we can't measure, sir. The proximal and distal extent of the lesion, the area or the distance from the central incisor where it is involved, whether the GE junction is involved or not, fundus, cardia, and the remaining part of the stomach, like body fundus, whether a pylorus, whether it is involved or not.
So we need to see, one is location of the disease, yes, length of the tumor, and area involved by the disease.
Yes,
then we also need to see what is the circumference involved by the disease. And another important thing is whether the disease is obstructing or not. So what is the amount of obstruction that disease is creating?
Yes, sir. Whether a scope is negotiable
all these
or
findings
not
is important. Okay. So this is the finding. Ulcerative lesions starting from 39 centimeter from incisor and involving abdominal esophagus, GE junction, and cardia. Biopsy, motilely differentiated adenocarcinoma.
Before
So
we
now,
go ahead, can I interrupt you, Devendra?
please.
Yeah. So another thing, after you've taken the history, please do not forget the clinical examination. Even if you don't have a real patient, you have only a scenario given to you. You have to tell the examiner that I would like to now examine this patient, and please tell them the salient points in general as well as the regional examination. So in a patient with a CA esophagus, you're not going to get many findings except probably a supraclavicular node if it is there, or if it is very advanced disease, then probably, if he has large liver mets or palpable liver. More than that, you're not going to get, but it's very important to mention that. And always mention the grade of dysphagia. So if your patient is dysphagia grade 3 or 4, that he can't even take liquids easily, then you have to say that I would like to feeding tube across as the first thing, or start IV fluids, correct all the electrolyte imbalances if he's going into pre-renal failure. So those are the emergency measures that you would like to mention. Yeah, we can go ahead. Yes. Sorry.
So Dr. Koteswar Rao, what will be the next investigation? How you will do the metastatic workup for this patient once this patient comes to you with this upper GI endoscopy and biopsy report?
Sir, once I confirm the disease as a moderately differentiated adenocarcinoma, I want to stage the disease. I will do contrast enhanced CT scan of thorax, abdomen, and pelvis. In CT scan, I want to see the location of the disease, site, size, extent, and adjacent structure involvement, and thickness of the disease, and along with proximal as well as distal extent of the disease and nodal involvement in the chest as well as abdomen.
Okay, fine.
And I want to see the liver status.
Right. Given a choice, PET CT versus CECT, do you have any preference?
Sir, in our institution, we will do PET CT scan, sir. If patient is not affordable, then I would like to go for the CECT scan of abdomen.
Perfect. So for exam purpose, I will say that all patients are fully affordable. Never think of unaffordability. Okay. Stick to the guidelines. Let the examiner ask you whether the patient is affording or not. So perfect. This is the finding. Similar finding, 57 millimeter length involving lower esophagus, GE junction extending up to the cardia, wall thickness around 26 mm. And there are perilesional fat trending along with multiple perigastric lymph nodes.
So Koteshwar and Ved Prakash, even if you don't know the name of the trial or the number of patients in the study, please remember that there is level 1 evidence for doing PET CT in adenocarcinoma of the GE junction. It upstages the tumors by 20%. So you have to remember that it is essential and what this guideline is based on. And if you quote a guideline, then say which guideline you have read. There are many guidelines which are there in practice. So if you're reading NCCN, stick to that and say NCCN. So the examiner knows that, you are not just bluffing. So even if you don't know the name of the trial and the number of patients, that's absolutely fine.
So with the PET scan is essential in every GE junction tumors?
So usually if your biopsy is not signet ring, if it is adenocarcinoma, then we should do PET scan and it will upstage the tumors by 20%.
No, are you talking about type 1, type 2, type 3? What are you talking about?
We would do for all 3 types, yes.
All right.
Okay.
So Dr. Ved, looking at the endoscopy and scan report, what is your probable clinical stage and how you will put this patient in terms of sievert type?
Sir, here the tumor is the length is almost 6 centimeter and thickness is almost 2 centimeter. So it and the patient is having dysphagia. So it is at least 3 stage T3, and there are multiple perigastric lymph nodes which are enlarged. So it is T3 N1. So that is stage 3 clinically.
Perfect.
So
There is no.
I will just butt in before you go ahead. So
Yes.
when you're talking about T3 in esophagus, and I think also in stomach, it is not based on the measurement of the length and the breadth and the width of the tumor. The T stage is determined by the invasion of the wall of the organ involved. So if
Yes,
you
ma'am.
want to say because it's 6 centimeters, I'm calling it T3, that is not correct. The correct TNM staging for esophageal and gastroesophageal junction tumors is based on the involvement. But why do you call this as T3 on a CT or a PET CT is because the tumor is visible and you can see the thickening present. If it is T1 or T2, you will hardly be able to see anything. There will be just mild focal uptake on the wall, if at all. And T4, you will see infiltration of the surrounding tumors. So if you see a thickened mass, most likely it is T3. Okay. So
Yes.
you have to remember that in different organs, the TNM is different.
What makes it
Yes,
T3 is perilesional fat stranding and not the length of the tumor, right? And
Yes,
how
sir.
about Sievert typing? What is your problem with it?
Sievert type 1, sir. I keep it in Sievert type 1 because it is starting from 39 centimeter from the central incisor.
So how you differentiate type 1 from type 2 and type 3?
So Sievert type 1 is when the epicenter of the tumor is between 1 and 5 centimeter above the GE junction. Type 2 when
What is the definition of epicenter? Is it a starting point?
No, sir. It is the center of the tumor bulk.
Center of the tumor. Okay. So according to now your, let me show you another, image. Can you see this?
Yes, sir.
So according to this image, what do you think will be the epicenter of the tumor? Will it be in lower thoracic esophagus or will it be near the GE junction? Or will it be below the GE junction?
Near the GE junction, sir.
So
it becomes type 2, sir. Type 2.
Type 2.
Dr. Koteshwara, would you like to say why this is type 2?
Man, it is the its tumor bulk is more in the level of the second level of the Sievert's 2 region, man. Tumor epicenter is at the level of the Sievert's 2 region.
Yeah, so it is at the junction of the esophagus with the stomach. Yeah. Do you know on what basis is the Sievert classification? On what is it based?
Yes, ma'am. It is depending upon the extent of location of the epicenter of the tumor location is placed. In a type 1, if it is more above to the junction 1 centimeter to 5 centimeter, it is a Sievert 1, and 1 to 2 centimeter below the junction is a Sievert 2, and 2 to 5 centimeter into the cardiac side is a Sievert 3.
So that is the classification, but what is it based on? How did they come about bringing about this classification?
Sorry, ma'am.
Okay, fine. We'll cover it later. Okay, go ahead. Go ahead, Devendra. The next question.
Yes. So Dr. Ved, now would you like to do any other investigation for this case, or would you like to start with the treatment?
Sir, I would like to do diagnostic laparoscopy, sir.
Diagnostic laparoscopy. Would you like to do diagnostic laparoscopy for Sievert 1 also?
So according to recommendation, it is for Sievert 2 and 3, sir, it is recommended.
Correct.
For type
Correct.
1, we can consider.
So for
what is the
okay,
for type 1, it is not recommended at least. And what is the practice?
It is optional. If you have a large nodal burden or you're expecting serosal disease, then you can do for type 1 also, but type 2 and 3 definitely you would do. So, Koteshwar, now, you agree with him that we have to do staging laparoscopy?
Yes, ma'am.
Yeah. So now we are not planning immediate surgery for this patient, are we? So why do you want to give him 2 anesthesias? Do one staging lap now, then do the surgery later. Why not do the staging lap later on with the surgery? what is the basis of doing this staging laparoscopy before you start any therapy?
Ma'am, I want to evaluate the metastatic disease in the abdomen, like liver, peritoneum, nodal disease, and any other tumor sites are there. So that will change the plan of the management.
So you don't think your high resolution CT scans or PET scans are good enough? Why not?
Ma'am, less than 5 millimeter tumors or tumor nodules cannot be picked up by the CT as well as PET CT. So I would like to go with the laparoscopic, staging laparoscopy.
Rightly said. And like Dr. Suraj was also trying to say that, you know, the adenocarcinoma, especially which are the diffuse or the intestinal type, may not have much uptake on the PET. So they may, the metastasis, the peritoneal, the mental metastasis, which are typically less than 5 millimeters, may not be picked up at all on imaging. So a diagnostic laparoscopy is important. Would you do ascitic fluid wash also, a cytology also along with this, or only a diagnostic laparoscopy is enough, a staging laparoscopy?
Yes, ma'am. I would like to do the diagnostic cytology examination also.
All T3 and N plus shall be given. So whenever you are doing diagnostic laparoscopy, peritoneal cytology shall be taken.
Yes.
Okay. So
how will you base your management on the peritoneal cytology positivity or negativity?
Sir, if there is no any gross disease and only peritoneal cytology is positive, even then we'll go ahead and give him the chance of cure, sir. We'll be treating as curative intent.
Okay.
But if there is grossly metastatic disease, then sir, in diagnostic laparoscopy, it will upstage the disease in 20 to 25% of the cases, and it will change the management in 40 to 45% of cases. So if there is grossly metastatic disease, we can consider for palliative treatment. But if there is only peritoneal cytology positive, then we'll be going ahead with curative intent and we'll send for a neoadjuvant treatments.
Okay.
Right. Sounds good. Okay.
So now, Dr. Koteswar Rao, which neoadjuvant treatment you would consider in this case?
I would like to go for neoadjuvant chemotherapy and radiotherapy. Sir.
Neoadjuvant chemoradiotherapy. Dr. Rao, Dr. Ved?
Yes, sir. I would also go ahead with a neoadjuvant chemoradiotherapy, sir, according to
neoadjuvant chemoradiotherapy. What dose and what duration do you want to treat this patient with neoadjuvant chemoradiotherapy?
Sir, it will be according to cross protocol, sir. I'll be giving paclitaxel as a chemotherapeutic agent weekly for 5 cycles, and radiation therapy 41.4 gray, 23 fraction, 1.8 gray per fraction.
True.
So would you consider instead of preoperative chemoradiation, only preoperative chemotherapy in this situation?
Yes, sir. That can it is under debate, sir. That is also another option, sir. But severe type 2 is considered as esophageal tumor, sir. So that is why I am going ahead with cross protocol. Rather, I would prefer perioperative chemotherapy in severe type 3, sir.
Okay. What is Sabita? Sabita, what is your opinion? I would love to have your opinion on this.
So basically, whether you give the answer as neoadjuvant chemoradiation or perioperative chemotherapy, both the answers are correct. We have good level 1 evidence for both. But when the biopsy is an adenocarcinoma, I would prefer to go ahead with perioperative chemotherapy with the FLOT trial, because it was mainly a larger trial and both the arms had some form of perioperative treatment being given versus the cross trial in which one arm was only surgery. And even though 75% of the patients were adenocarcinoma, the benefit was mostly driven by the squamous histology. So I would definitely think about giving perioperative chemotherapy rather than neoadjuvant chemoradiation.
So Dr. Ved, what do you want to change your opinion now?
Or you already sent the patient?
See, at my center, Kolhapur Cancer, all these patients go for neoadjuvant chemoradiation. And we have excellent results with that. Dr. Sabita follows a different protocol at TMH, maybe a different kind of a protocol they have at TMH. but there's definitive evidence that cross protocol.
So that's what I said, that you will not be wrong if you say, choose any of them. There is evidence for both. We just do the FLOT protocol for adenocarcinoma.
Between FLOT and cross protocol, we have to understand that at this point of time, till ISOPAC trial comes, debate is open and we can select the cases for FLOT versus cross. But whenever there is a higher risk of systemic failure, we have to understand that FLOT will be more helpful to the patient.
No, so there are some studies coming up.
Esophageal lymph node positivity, then those cases will be beneficial to go for perioperative chemotherapy.
So there's a lot of discussion, debates about this, whether NA-CTRT or the FLOT protocol. And there's also issue coming up whether NA-CTRT followed by surgery, followed by adjuvant chemotherapy. So this debate is open and we had to decide the protocol as per the institutional.
So this particular patient received 4 cycles of perioperative FLOT-based treatment, and at the end of treatment, this was the imaging at the end of 4 cycles FLOT. Yes. Dr. Ved, would you like to comment on this imaging?
Yes, sir.
Are you satisfied with the response?
Not truly, sir. There is only a partial response in the thickness and length of the tumor. Also, the length has reduced from 57 mm to 39 mm, and the thickness is almost similar. So there is partial response in the tumor.
Still, you are not satisfied. So what is the aim of giving perioperative treatment?
So the aim is to downstage the tumor, sir, to take care of the micrometastasis, to have better local control of the
prevent metastatic failure or systemic failure. So as long as patient is not progressed, we are happy with that. Correct?
Yes, sir. Yes.
Stable disease or partial response or complete response. In all 3 cases, treatment remains the same. Okay. I would like to invite examiners to ask for the surgical management.
Yeah. So what would you like to do next? Any of you can take that question, please.
Dr. Kodeshwar Rao.
Sir, I would like to do Ivor-Lewis esophagectomy, sir. Transthoracic esophagectomy with gastric gastroesophageal anastomosis with 2-field lymphadenectomy.
What about you, Dr. Ved Prakash? Do you agree?
No, ma'am. Actually, I would like to go for a pre-rehabilitation of the patient with nutritional improvement.
We have done everything. Now patient is on table. What you will do?
Okay, and then
patient is fully fit to undergo surgery. Now anesthetize.
Then I'll go for transthoracic esophagectomy only, sir.
I mean, you agree with Dr. Kodeshwar Rao? You want to go for Ivor-Lewis or left thoracoabdominal or transhiatal or thoracoscopic, robotic? What is, all options are there. What do you want to do?
If all options are there, so then I'll go for minimal invasive surgery, sir. Minimally invasive surgery, Ivor-Lewis, sir, esophagectomy with 2-field lymphadenectomy with esophagogastric anastomosis.
So when you do, both of you are planning to do Ivor-Lewis esophagectomy, right? What yes, margins you will take proximally as well as distally?
Proximally 5 centimeters, sir. And distally? Distally 2 centimeters, sir.
You can do Makivan also. If you want to take 2 centimeters, you can do Makivan also in this case. If you are aiming for Ivor-Lewis esophagectomy, why you want to do Ivor-Lewis and not Makivan? this case can be finished with McEwen esophagectomy. Why you want to do Ivor Lewis?
Can you all tell me the differences between the two esophagectomies, the Ivor Lewis and the McEwen?
Yes, ma'am. In Ivor Lewis, we do thoracotomy and esophagogastric anastomosis. So the anastomosis is inside the thorax. So there is a high chance of mediastinitis if there is any leak.
No. Before we talk about the complications, tell me the steps of surgery, the broad steps of surgery. What will you do first?
Okay, sir. In Ivor Lewis, sir, we'll open the first do abdominal part of the surgery, and then after mobilizing the stomach and the distal esophagus, and then we'll move on for thoracotomy, and after doing a thoracic incision and esophageal dissection, we'll take 5 centimeter proximal margin and then resect the tumor.
Okay. And what is the difference with the McEwen? What will you do in a 3
In
hole?
McEwen, we have, in addition to abdominal and thoracic incision, we have the cervical incision. And so we'll be doing esophagogastric anastomosis in the neck.
Dr. Koteshwar Rao, what are the steps of a McEwen's esophagectomy?
In McEwen esophagectomy, I would like to go for first transthoracic dissection to see the location of the esophageal tumor and what about the extent and adjacent structures. And after mobilizing the tumor, after dissecting the disease, I would like to go do the laparotomy and dissection or the abdominal part, and then I will go over the cervical neck dissection. And I would like to do anastomosis in a cervical region. With the
Any other approaches you all know about for esophagectomy? What are the other 2-3 approaches that are available?
Another approach, transhiatal approach, that is a Oringer's approach. Here we will do the laparotomy, mobilization, blunt dissection, and cervical dissection and anastomosis. And another approach, left thoracic approach and abdominothoracic approach.
Okay.
That's
a single incision, single position approach, left thoracoabdominal.
Yes,
left thoracoabdominal.
Yes,
so now just tell me the 1 or 2 reasons why you all are choosing Ivor Lewis over any other approach for this patient with this tumor.
Ma'am, one thing is location of the tumor. It is 39 centimeter. Tumor is epicentered at the level of the 39 centimeter. In the imaging, the tumor is more towards the lower part of the esophagus. And here, and one more point is, it is near the junction of the stomach. So I can divide the esophagus and then I can remove the 5 centimeter proximal as well as 5 centimeter distal margin and make a gastric conduit and anastomosis the esophagogastric anastomosis in the thorax.
Yeah, that's a fairly good answer. Nobody will judge you for saying wrong. Dr. Devendra was just trying to ask you that if possible, would you also like to do a McEwen's? But if you want to stay safe, then any gastroesophageal junction tumor which has a component which is going into the stomach and you want to do Ivor Lewis, you want to explore the abdomen first, check the operability, see if the conduit will reach the neck or the thorax, then it's better to go ahead with the Ivor Lewis. And you can also adopt the left thoracoabdominal approach, but in that the lymphadenectomy will be limited. So that's why you would prefer Ivor Lewis. You could answer like that.
So, Sabita, I just want to make a point here. Because, in the total esophagectomy with upper partial gastrectomy for Indian stomachs are large. They're not like the Japanese stomachs or the Western stomach. So I always prefer to do in these kind of situations. Maybe Ivor Lewis is ideal, but otherwise, total esophagectomy with the anastomosis in the neck is a very good option for the Indian scenario because our Indian stomachs are large. And in that situation, that can be a safe option to have anastomosis in the neck. And at Kolhapur Cancer Center, we always prefer to have the anastomosis in the neck, and with equally good results, that also can be a good option.
Yeah, so both options
Okay.
are correct.
Both
If
options
you're
are
not sure
required.
of distal margin, then you can do a McEwan's. Your conduit will
Sure.
come to the neck. If you're not sure of your distal margin, you want to take a wider margin on the stomach, then please do a Ivor-Lewis or a thoracoabdominal approach. Okay. Devendra,
Perfect. So,
anything you want to add?
I guess we shall go to next case in the interest of time.
Yeah, we can.
So this is about second case where now we will start with rapid fire. 78-year elderly male, moderately ill, moderately nourished, complaint of dysphagia for 10 days and weight loss of 3 kg. Performance status good, ECOG 1, general examination NAD. On investigation, this is the upper GI endoscopy finding. This is the biopsy, poorly differentiated adenocarcinoma, and PET CT scan is saying, I'm not able to see, 52 by 18 mm without any lymph node. So quick comment, what is the stage, what is the severe type? Would you like to comment fast? Dr. Ved, Dr. Koteswar Rao.
Sir, it is CO type 1 adenocarcinoma.
Fine. And what about stage?
Stage, sir,
Looking at the imaging.
T3N0, sir, T3N0, M0, MX.
Okay. Considering the age of the patient, what will be the line of treatment you would like to offer to this patient? 78-year, otherwise fit patient.
So we would like to do, sir, this PET CT scan, sir. We have not performed PET CT scan.
Oh.
He already mentioned in the previous.
This is PET CT scan only.
Okay. Yes, sir. Sorry.
This is, now you are agree that this is PET scan?
Yes, sir.
Okay. So what next?
So
would you like to do a staging laparoscopy for this patient also, like the previous patient?
No, man, no. Because there is no nodal disease and it is severe type 1. So we can go ahead with preoperative treatment.
Okay. What Devendra is trying to ask you is, in a 78-year-old male, would you think of giving multimodality treatment?
But her performance status is, sir, is ECOG 1. So she can tolerate perioperative chemotherapy.
Between cross-based chemoradiation and plot-based perioperative chemotherapy, what is the more toxic regime?
Plot 4 regime is more toxic, sir.
Plot 4 is more toxic regime. So,
Suraj, would you like to add anything?
But in trial, they showed it is not toxic.
No,
the toxicity was not that significant.
I agree with what Ved is saying. But CO type 1, any CTRT as a new adjunct with the treatment of choice, there's no question about it. And then there's evidence on that any CTRT in this patient would be the treatment of choice, and we reassess.
perfect.
I think that would be ideal. Yeah.
So this is the picture at the end of neoadjuvant treatment. Stable disease. What is the surgery you would like to offer? Patient is fortunately well preserved at the end of neoadjuvant treatment. 78-year male. Dr. Koteswar Rao. I am seeing both of you.
Sir, I would like to go for the Oringer's transhiatal surgery with cervical anastomosis.
Why Uringer? So you are talking about transhiatal esophageectomy.
Yes, sir.
Why
As
transhiatal esophageectomy?
there are no imaging noted nodal disease, and patient is a 78 years old gentleman. So according to his age, although he is a medically fit, but according to his age, I would like to do cervical anastomosis.
In addition, he has a comorbidity, diabetes, and hypertension.
As well as,
so that can add to to the
Yes, sir.
morbidity in the post-op period. So
Okay.
we'll go
Fair
ahead
enough.
with transit.
Transital. So I guess you both are running in tandem. That is fine. What is the advantage of THE over transthoracic? If one does nicely, like Dr. Suraj or Dr. Sabita, if someone does nice minimal invasive surgery, thoracoscopic, or then what is the advantage of THE over
Sir,
transthoracic?
there is less of the pulmonary, as there is no thoracotomy, there is less pain, so there is less pulmonary complications. There is
Comparison
less,
of thoracoscopy versus THE.
yes, sir. TTE and THE, sir. Transthoracic and.
So unfortunately, Devendra, they don't have a trial comparing minimally invasive esophageectomy with transhiatal. The
Right.
largest meta-analysis show that THE has less pulmonary complications.
Exactly. So that is
Yes,
the answer.
sir.
Take off
So
the
by doing transhiatal, you can avoid only pulmonary complications. So
Pulmonary
if your lungs are permitting, it is always better to go for transthoracic approach. Frail
Okay, sir.
patient where you are anticipating lot of lung related problem, that is the only area where you will consider transhiatal esophagectomy. Otherwise, age is not a bar. Okay.
Okay.
But fair enough, transhiatal is also accepted modality. We'll go ahead. Any question, Dr. Sabita or Dr. Suraj, or I can go to case 3?
No, I was just trying to ask Dr. Koteshwar Rao that he was talking about the age factor, and as Devendra just mentioned, age should not be a limiting factor whether you're doing a THE or if you're doing a transthoracic open thoracotomy. I agree to what Devendra or Sabita just mentioned, but if you're doing a thoracoscopic vis-a-vis THE, age should not be a factor because both are minimally invasive, and thoracoscopic would be as minimally invasive as transhiatal with an advantage of additional lymph node dissection. So in expert hands in a high volume center, thoracoscopic would have an advantage over transhiatal esophageectomy. What do you say, Sabita?
Yeah, definitely. We have to look at the physiological age of the patient, not the chronological. Discuss the patient in a multidisciplinary meeting, discuss with your thoracic anesthetist. And if you have a go ahead, check the lung windows. Patient does not have history of COVID or COPD. Check out all that. And if the patient is fit, please go ahead and do a minimally invasive transthoracic esophagectomy. But if the examiner asks you, what will you do? And specifically you, and if you have to then decide based on where you are working, what is the expertise available? Do you have availability of minimally invasive surgery? Are you confident enough to do it? So if they ask in general, then the answer is minimally invasive TTE. If they ask specifically, what will you do? Then you say the answer which you will be able to back up with your justification. Okay, so in the exam, always make your answer close-ended. Don't let the examiner ask you one more question. Justify whatever you say.
Sure.
So let us move to case 3. 62-year female, complaint of abdominal pain in epigastrium for 1 month and dyspepsia for 1 month. No weight loss. Good performance status. On examination, there is a vague lump in epigastrium. So this is the clinical finding we have. What is the differential diagnosis whenever such presentation is there? Abdominal pain with lump in epigastrium. It will be very vague. Let us straight away go for imaging.
It will.
In the interest of time.
Yes, sir.
We have CT scan. Let's. Dr. Ved.
Yes, sir.
Can you read this image for me?
Yes, sir. There is a extensile mass in the arising from the posterior wall of the stomach, which is pushing into the stomach, and expansile it is going outward. It is free from the aorta.
There is second image as well if you want to read.
It is completely exophytic mass, sir, arising from the stomach.
Okay, so it is a 8 by 7 by 6 centimeter lesion arising from the cardia and fundus of the stomach. This is the endoscopic finding. Would you like to do biopsy, Dr. Koteswar?
Sir, as it is showing as a upper GI scope, it is showing as a submucosal bulge, and as well as CT scan images are showing the mucosal layer is smooth. So I would like to go for the endoscopic ultrasonography with, if possible, as well as biopsy, sir.
So would you like to go for biopsy in this case? You are saying yes for biopsy, yes?
Yes, sir. Yes, sir.
Okay, and modality will be endoscopic ultrasound guided biopsy.
Yes, sir.
Is it possible to go for upfront surgery without biopsy in such present case? What is the probable diagnosis we are anticipating here?
Sir, it is a submucosal bulge, sir. So submucosal location of the tumor, it might be the gist.
So if you're going to say one answer, the examiner will think you know the case already. So you say my differentials are 1 and 2. At least give 2 differentials, right? Because we are doing a mock exam. So what would be your differentials in this case? A well circumscribed mass, which is exophytic outside the lumen of the gastroesophageal junction and stomach. What do you think it could be?
It could be the tumor arising from the gastroesophageal junction, ma'am.
Yes, but what do you think it could be?
It could be the one is as usual. Most common is a carcinoma stomach.
Is it looking like carcinoma stomach?
No, sir.
Then why you are saying that?
Give a differential diagnosis. DD is
looking at the picture of CECT and this upper GI endoscopy. What are the differential? 1, 2, 3.
DD.
My DD. I'm getting on just only to the my mind because
can it be neuroendocrine?
Neuroendocrine
tumor, gastric lymphomas.
Lymphomas.
Will be very rare.
Thing which is much more common than GIST or lymphoma.
Benign pathology. Can you think of any benign pathology? Which is far more
sorry,
common.
Leiomyoma.
Leiomyoma.
Not sarcoma.
Sorry, leiomyomas. I'm sorry.
Okay. Perfect. So if you are doing endoscopic biopsy, that is okay. Can you do CT guided biopsy in such cases?
Yes, sir. It can be.
Whenever you are anticipating a probable diagnosis of GIST, can you do CT guided biopsy? I am reframing my question.
Sorry, sir. I'm not aware of
Yes, Prakash, would you like to take that?
Yes or no?
No, not requirement.
Will you do CT guided biopsy if you are anticipating GIST? Yes, no.
Yes. So
I'll see for whether it is resectable or not. If it is resectable, then I will go for.
If it is a metastatic disease,
then I need biopsy. Then I need biopsy, sir, to start this imatinib pre-op in imatinib.
What is the risk of CT guided biopsy in a gastric GIST, suspected gastric GIST?
Bleeding, sir. There is risk of profound bleeding.
Catastrophic bleeding.
Yes, sir.
In morning you will do biopsy, in afternoon you will have to do laparotomy for bleeding. So better to do endoscopic biopsy if at all you want to do. Fine. So how you will manage this case? It is a case of without any metastatic, confined to proximal stomach.
Can I just interrupt Devendra for a minute?
Please.
You talk morning, you do biopsy, and then you explore in the afternoon. Is there a role of hemostatic radiation therapy in such a situation?
Hemostatic radiation therapy.
It works.
Yes, but I would like to let this examiner answer first. Dr. Ved and Dr. Koteswar.
Yes.
Yes, sir.
You do biopsy of this kind of tumor, it starts bleeding. you do biopsy in the morning, in the afternoon it starts bleeding. Would you like to go in again and explore, or is there an option of hemostatic radiation therapy because it's a oncological comprehensive
Sir,
meeting
because
there?
it is a catastrophic bleeding, sir, then I would go for exploration and laparoscopy. Exploratory laparotomy, sir.
Koteshwar Rao?
Yes, sir. If I anticipate any catastrophic bleeding, then I would like to go for the surgery.
Sabita, what is your experience in such situation? Hemostatic RT.
For GIST, sometimes it works. You can also try angioembolization. That works better. And the other thing is this risk of catastrophic bleeding we have read in the textbooks, but it is not very common. It is very rare. And if you have a contrast enhanced CT and you have an experienced radiologist, they can guide the biopsy well. So, and the risk of seeding is less than 1%. So you're not totally wrong if you say that I can do a CT guide biopsy with a contrast enhanced CT with an expert radiologist. I don't think the risk of bleeding is more than 1%. But preferable is to go by the endoscopic route, US and guided FNA or biopsy. But why would you want a biopsy in a resectable mass? That is the question. That is the main question that we need to address.
Right.
Okay.
Why do you want a biopsy? It's a resectable mass. You can go ahead and operate. Why do you want a biopsy?
Yes.
Now I'm asking you a question. I want a biopsy, but tell me why you want a biopsy, both of you.
So, ma'am, in order to rule out the diagnosis, like we had a differential diagnosis of neuroendocrine tumor, leiomyoma, and GIST, ma'am. Therefore, we need to establish the diagnosis. And ma'am, in this case, the disease is extending up to GE junction. So only while local excision will not suffice, we may need to succumb to a proximal gastrectomy for this patient.
Correct. That is the main reason. The thing is that if your two main differentials are a leiomyoma and a GIST, now the approach to surgery for both of these will be very difficult. In leiomyoma, you do not need margins. You can enucleate the leiomyoma if possible. If you do not cause mucosal injury, you can go into the submucosal plane, enucleate the leiomyoma. But if you have a GIST, you need some amount of margin. You cannot do enucleation for such a large size GIST, especially. It is not oncologically safe. And especially if you have large GIST, you also have an option. If your patient is not very fit, has become cachectic due to dysphagia, you can also give imatinib before the surgery. So you have these options. So it's better to have a tissue diagnosis.
So because there can be a rare differential diagnosis of a lymphoma, gastric lymphoma, where you may not need a surgery at all.
Yes, then it would be just chemotherapy and the tumor would melt. So
and that's the reason we need a preoperative biopsy.
Always we need a biopsy.
That be endoscopic biopsy.
Devendra, anything else to add in this case?
Actually, our radiologists were pretty sure about the clinical diagnosis, and so this patient underwent, as Dr. Koteshwar said, proximal gastrectomy. And last slide, case 4, and then we will sum up. 61-year doctor himself, well-built, moderately nourished, weight loss, only significant complaint. There was no dysphagia to this patient. Again, ECOG 1, and this was the clinical picture.
Srijan has indicated we don't have much time. So I
think only 2 minutes.
Yes.
Point blank, Dr. Ved first, Dr. Koteshwar Rao second. Please read it fast and quickly comment for the treatment management.
Yes, this is CA esophagus in the middle thoracic of esophagus, extending down up to the GE junction and fundus. So it is a long length CA esophagus in the middle third of the esophagus. So here we need to do bronchoscopy. In order to stage the disease, we will be doing bronchoscopy to look for any tracheal or bronchial lesion.
Then
along with and then PET CT scan to look for any distant metastasis. If it is
non-metastatic,
if
it is non-metastatic,
then we'll because the performance status is ECOG 1, sir. We'll plan for definitive treatment, sir, in the form of neoadjuvant CTRT. Before that, we'll be doing diagnostic laparoscopy, of course, sir, and then send the patient for a neoadjuvant CTRT.
Okay, stop there. Dr. Koteswar Rao, would you like to do anything differently or exactly same?
Sir, I would like to do PET CT scan and staging laparoscopy. And I would like to improve his nutrition status.
But what about the neoadjuvant approach? What would you choose? Are you happy with neoadjuvant CTRT or do you want to think differently?
Yes, ma'am. I would like to go for the neoadjuvant chemo radiotherapy.
So this length of the disease is 16 centimeters. It's 160 millimeters. You think neoadjuvant chemo radiation?
What are the What are the exclusion criteria of cross protocol in their own original study?
So I'm sorry, I could not remember.
Okay, so length was one of the exclusion criteria. Long segment disease, more than 7 centimeters, I guess 5 or 7. I am not exactly remembering.
Yes.
Okay.
So we can offer a definitive CTRT in this patient.
Then
even for definitive CTRT, you have to remember that the maximum length that a radiation oncologist can treat radically is 10 centimeters because they have to give margins above and below. So this is already 16 centimeters to start with.
So I would like to go for the neoadjuvant chemotherapy, ma'am.
Perioperative or neoadjuvant, you can say.
Perioperative.
Perioperative.
But okay, you've given neoadjuvant and the disease, like in Devendra's other cases, has remained stable. What is your surgical approach? What are you going to do with this patient?
Then I would like
half the stomach is involved, half the esophagus is involved.
Then I would like to go for the McEwan's total esophagectomy.
And after doing McEwan's, what will you get it up in the neck? What will you anastomose?
I would like to anastomose with the jejunal esophageal anastomosis.
Jejunum will come up to the neck? You're planning to do free jejunal flap or what? Pedicle jejunum?
I would like to do the free jejunal flap, ma'am, if it permits. Otherwise, I'm sorry.
Dr. Ved?
Ved, anything else?
We can use colon as a conduit, ma'am.
Yes. Definitely you can use colon as conduit, but you have to remember that if you're planning a coloplasty, your patient has to be extremely fit because there are 3 anastomoses. There will be esophagocolic, gastrocolic, and colocolic. So you will not offer it to anybody and everybody. You have to make sure your patient is extremely fit.
Okay. So this gentleman underwent perioperative treatment and total esophagogastrectomy with colonic transposition. And with this, I would like to thank you all. I'm sorry for 5 minutes late. And I'll hand over to Dr. Srijan.
Thank you, Devendra. Extremely diverse and interesting cases. Good discussion.
Thank you, madam.
Thank you, examiners.
Thank you very much, Dr. Savita and the examiners and the examinees. Really educative and very, very interactive. And the best part was that not only the GE junction, but a wide range of things could be discussed besides the adeno-CA. The GIST, the leiomyosarcoma, everything was done. So beautifully done. So thank you very much to all of you and to Srijan and the organizers. Thank you.
Thank you so much, Dr. Kapoor. I invite our examiners, Dr. Sabita, Dr. Pawar, and Dr. Devendra to kindly rate our students for today and any tips if they have to happen to get this case in exam, which is very less likely, but still.
Start with Suraj. He's the senior most.
You're muted.
You're muted.
Both were very good. I think both were very well read. I was very happy the way both of them answered the questions. I would rate them. I would rate both of them like 7.5 out of 10. They passed my examination.
Ma'am.
Yeah, definitely. I agree with Dr. Pawar. 7 is what I would give also. But I just want to tell Dr. Koteshwar Rao that he needs to speak out on his own. I mean, the examiner cannot keep asking him, okay, what are you going to do next? Do you agree with me? Do you disagree? In a real exam, nobody's going to spoon feed you so much. So please speak out on your own.
Sure.
And our moderator, Dr. Parikh.
Yes, again, both of them have done fantastically well. Only one comment that whenever you are asked, there is a limited time in exam. So you have to be very fast and let the examiner stop you. You have to keep speaking. That is the only comment. Otherwise, you have done good job.
Yeah, totally agree with Dr. Devendra that it is not you answer, it is how many questions you answer that matters. So be very crisp and lead the examiner to what you know. That is also very, very important, that your answer should lead the examiner to something that you already know, which they can ask and go ahead with that.
Thank you, everyone. So valuable inputs. Dr. Koteshwar is in his second year right now, whereas Dr. Ved is exam going. So I'm very sure Dr. Koteshwar is going to, really go up from here and come back stronger next year. We move on to the next segment, which is the expert talk, and we invite our faculty for today, Dr. Sabita Javnani. Ma'am, we are all ears. You're muted. I'm sorry, Dr. Sabita.
I'm sorry, 1 second. Yeah, can you hear me now?
Yeah.
Yeah, okay. Sorry about that. Yeah, so I have tried to encompass all the evidence that we have in gastroesophageal junction tumors. But since we have covered a lot of points during the case-based discussion, I will skip through those slides or go through them really fast in the interest of time. So coming to gastroesophageal junction tumors, it is really a gray area between the esophagus and the stomach. And we know that this tumor is becoming more and more prevalent. The incidence is rising. It was initially in the Western world, but now even we are seeing more and more of these tumors. The epidemiology of esophageal cancer has really changed in the last 2 decades, and it is now coming and catching up in the developing world also. So the burden in the East, we have seen that the age standardized incidence of esophageal cancer is declining in Asian populations, such as India, as well as the esophageal cancer belt, the exceptions being Japan and Israel. And we can see over here in India, this is a registry from Chennai and Mumbai, that the age standardized ratio as well as the crude rate is declining in males as well as females. In the West, the gastroesophageal junction tumors really peaked in the 1990s. They started peaking in the 1970s, and this was an epidemic of obesity, of gastroesophageal reflux disease, which drove this epidemic. And there was a kind of exponential rise in the adenocarcinoma, and then it stabilized, and the distal adenocarcinomas kept reducing. There's significant racial disparity in this, but there are a lot of thoughts about this, that this is actually because of better socioeconomic condition, the change in the diet, the growing of obesity and decreasing of H. pylori infections. There are a lot of genetic and molecular studies which are being done to see if gastroesophageal junction is a distinct entity from the gastric carcinoma, or is it something which is arising from the esophagus. And most studies now agree that it is actually just that the gastric adenocarcinoma has been moving proximally. So there are a lot of controversies in management. The controversy starts with the spelling of esophagus actually. Some spell it with an E and some spell it with an O. There is the controversy in classification, in the multimodal approach, like you saw. There was discussion among the examiners themselves what we should choose, the surgical approaches, and also now there is an emerging role of immunotherapy as it is in all cancers. Why is there no consensus? the problem with these tumors has been that most of the randomized trials have clubbed squamous with adenocarcinoma, and they have clubbed the gastroesophageal junction tumors with esophagus or with gastric, or taken all three together. So only examining the gastroesophageal junction tumors by themselves has been difficult, and the evidence has been, actually needled out from different trials, where seeing how much was the component of the gastroesophageal junction tumor patients that was taken in these trials. So there are various anatomical classifications that we have. The most commonly followed worldwide is the Seward classification. The Japanese follow the Nishi classification, and the AJCC recommends that we follow the AJCC classification. So like our examinees already answered what the Seward classification is, this is based on endoscopy by doing a J maneuver and retroflexing and seeing the endoscope through the stomach, seeing the tumor, by radiography, and also by looking at the surgical specimens and intraoperative findings. So this was a classification which was derived on the base of all these three factors. And the Nishi classification is a little more complicated, but it is mostly followed in Japan, so you don't need to know the details. And in AJCC, Seward 1 type 1 and 2 are classified with esophageal cancers, whereas the type 3 are counted as gastric cancers. Now we have to understand all these classifications hinge upon the epicenter of the disease. Now this epicenter is very notoriously inaccurate. The sensitivity and specificity of both endoscopy as well as radiology is approximately 70 to 75%. And it's very difficult to determine which the actual epicenter is. People have tried PET scan also to see where is the maximal uptake, but still there is no clear answer. So you will only get it with experience, seeing more and more cases, see the endoscopy, see the radiology, and also the intraoperative findings. Dissect your specimens after you've excised them, and then you will get a clear understanding of where the epicenter of the disease was. So we all know that surgery remains the primary curative modality as of now, but the prognosis is not very great. So that's why we need multimodality treatment, and there have been various combinations. And our goal, as always, remains that we have to eradicate occult micrometastatic disease and improve the local control, improve the surgical outcomes. So first, we'll start with neoadjuvant chemotherapy. There were two major trials which were considered as landmark. First was the Intergroup 113, which was actually a negative trial. And they did a subgroup analysis by adenocarcinoma also. There was no difference in overall survival. This was actually a very old study done in the 1990s. And the interval between the neoadjuvant chemotherapy and the surgery was anywhere from 2 to 8 weeks. So this is one of the reasons why it was criticized. And the staging was not standardized in this study. So there was another study which came out from UK, the OEO2 trial, where 2 cycles of cisplatin and 5FU were given. And this was compared to surgery alone. In this, the cardia or the junction tumors were around 10%. And they saw a 5-year overall benefit of 6% when you gave chemotherapy in addition to surgery. And this really got chemotherapy into vogue in the Western world, especially in Europe. At the same time, there were other trials which were comparing chemotherapy. And the earliest one amongst this was the MAGIC trial, which really changed the face of gastric cancers mainly, and how gastric and GE junction cancers were treated. Because it was always associated with a very dismal outcome. But then people saw that if you give chemotherapy before and after surgery, you are actually improving the survival by 13%. And for any one single modality to improve the survival this much in oncological trial was unheard of at that time. So this became one of the most landmark trials in spite of having inadequate surgery. So only 10% of the patients actually had a complete D2 in MAGIC trial, and in spite of that, only 40% took the postoperative chemotherapy, and still the survival difference was seen. So this was hailed as one of the landmark trials. But again, this came from the other side of the continent. So there was another French trial which reiterated that giving chemotherapy 6 cycles of cisplat 5FU versus surgery actually improved survival. And there were more patients completed all cycles of chemotherapy, and this survival benefit was seen. It was maintained. After this, this is a relatively newer trial, but this is also perioperative chemotherapy. So I clubbed it with this. Somebody needs to unmute. I don't know, somebody is talking. Yeah, so this is the famous FLOT trial, a robust trial which was multicentric and had a large number of patients, more than 700. And we saw in this that 27% of the patients actually underwent transthoracic esophagectomy, and gastrectomy with or without esophagectomy was done in 56% of the patients. The median overall survival was a stunning 50 months, something that we had never heard of, never seen of in esophageal or esophagogastric cancers, especially adenocarcinomas. The regimen was supposed to be more toxic, but they modified the regimen in such a way that it could be given on OPD basis, and they did not compare it to only surgery. They compared it to the gold standard at that time, which was perioperative MAGIC regimen, the ECF, which was the MAGIC regimen at that time. So they compared it with a standard, and you can see the survival in the MAGIC regimen arm was 36%, which was consistent with the results seen in the MAGIC trial. So the strengths of the FLOT trial were that the surgery was of good quality. It was 98% of the patients underwent D2. The median number of lymph nodes removed was 25, and the benefits were seen across all age, anatomic site, histology, and clinical stages. They looked at the hazard ratios of death for gastroesophageal junction tumors and also for stomach. It worked for both. 50% of the patients completed the therapy, and like I already mentioned, it compared it to another effective arm and not just only surgery. So this was comparing it to an already established standard of care. We have to talk about radiation because cross trial has changed the way we manage GE junction tumors all over the world. And first was the Walsh trial, which actually popularized chemoradiation in North America. So a lot of Canadian centers as well as North American centers started giving neoadjuvant chemoradiation on the basis of this study, which had only 113 patients. The morbidity mortality was higher in the tri-modality arm, but the overall survival was showing a huge difference. They did not accrue all the patients. It was very difficult to accrue, but this changed the way people thought about tri-modality therapy in esophageal adenocarcinoma. And soon after this came the cross trial, and here they had given a very low dose chemotherapy, 5 weekly cycles, and used a lower dose of radiation, and combining these two, they compared it to surgery alone. And they showed very good resection rates. R0 resection rate was 94 versus 69% in the only surgery arm. But when we are talking about GE junction tumors, we have to see what was the percentage of the GE junction tumors actually in this study. So if you look at this, there were 39 patients in the NACTRT with surgery arm and 49 in the only surgery arm. So less than 100 patients in the esophagogastric junction, and 75% of the patients were adenocarcinoma and 25% of the patients were squamous carcinoma. When we look at the survival curves, the huge difference that is seen with addition of neoadjuvant chemoradiation is in the squamous histology. And the number of patients in the squamous arm, you can see for yourself how many they are. And in adenocarcinoma, there is a benefit. Definitely there has been a benefit, but it is not as huge as the squamous histology arm. So can we actually, derive this data from this trial and apply it to all GE junction tumors? I think we should take it with a pinch of caution. It has shown good results, but the numbers of GE junction tumors in this study were dismally low. So going on, only 23% of the patients had GE junction tumors. This trial was relatively small, 300 odd patients. But when they published the 10-year results, the benefit was shown to be maintained at 10 years also. And the thing that they touted the most in this study was the pathological complete response. The pathological complete response rates overall were 29%, but most of this was driven by squamous carcinoma, 49% in squamous carcinoma. And the rates of pathological complete response and R0 was same in the adenocarcinoma as was seen in the FLOT trial. So should we give this cross regimen to all GE junction tumors, to squamous as well as adeno, and or should we limit it to only the group which benefited the most? So I am not comfortable using cross as the standard of care in all patients, because first of all, the benefit was seen in squamous histology, where the number of patients with squamous carcinoma were less than 100. Node negative patients did much, much better. The hazard ratio was 0.44 compared to node positive, where it was 0.8. The comparator arm was not a standard arm. In this era of neoadjuvant therapy, when it has been around for 3 to 4 decades, the comparator arm should have been more robust. And we have to remember that now more and more genetic studies are showing that esophageal adenocarcinoma or GE junction tumors are actually different from squamous carcinomas, and it is not right to club them together. Pathological complete response rate as well as R0 resection rate have still not proven to be true oncological surrogates of survival in any solid cancer, even in breast cancer, where it has been studied extensively. And when real world studies were published to replicate the same kind of survival benefit, which was seen with the cross trial, they were not able to demonstrate such a huge difference. There was a difference, it benefits patients, it improves survival, but the limitation was that the median length of the tumor, which was taken in the cross trial, was 4 centimeters. 81% of the patients in the cross trial had a performance status of 0 or 1. And the mean age of the patient in this study was 60 years. So when there are many papers in literature from the US as well as from Europe, where they have said that there is a benefit, but it is not as stunning as that was seen in the cross trial. Then we come to POET trial, which actually attempted to compare, neoadjuvant chemoradiation versus neoadjuvant chemotherapy, but they failed to accrue even half the number of patients which was required. And it was highly criticized study because there was a poor accrual over a long time, and they stopped. And there were utilization of non-standard chemotherapy as well as radiation regimens. So the NeoAegis study again then tried to, compare the two landmark trials. Cross versus MAGIC was their initial study design, but then FLOT was published. So they included the FLOT group also after 2019, and they saw absolutely no benefit. So both are that way, if you look at it, it's equal. You can go ahead and you can choose any one. They have said there are similar outcomes in both arms. When we look at the short-term results, because this NeoAegis trial, I could only find the abstract, the R0 resection rates were much higher in the cross regimen arm. 95% of the patients had a R0 resection. The YPN0, the pathological nodal response, was 60%. The tumor regression grade was 4 times that seen in the MAGIC or FLOT study, and pathological complete response was 3 times as much. But still, if you look at the survival, it is the same in both the arms. So even with a better R0, with a better pathological complete response, they have not been able to show improvement in survival over the perioperative chemotherapy arm. NeoRest trial, another one, which looked at 3 weekly cycles of cisplatin and 5-FU with or without the concurrent addition of radiotherapy at 40 gray. And all patients underwent esophagectomy with 2 field. The primary endpoint in this was a very soft endpoint, not survival, but pathological complete response. And they saw that the 5-year progression-free as well as overall survivals were not, statistically significant. So there are many ongoing trials, and you can just know the names. You don't need to know the actual, numbers, etc. Just know the names and the arms that they are comparing. Coming to the gist of what we want to know about gastroesophageal junction tumors is what should be the surgery that we should do for these tumors. The neoadjuvant approach, the perioperative approach, the adjuvant approach can all be discussed in a multidisciplinary meeting, but the surgery has to be decided by the surgeon who is going to definitely treat this patient. So like our examinee said, do a staging laparoscopy before starting the systemic or the neoadjuvant treatment. And we have to always remember that the aim is a R0 resection with adequate lymphadenectomy. So the general principles of surgery are based on the Siewert extension. That's why the Siewert classification is used more commonly than the other classifications. And also we decide the extent of surgery based on the histology, whether it is squamous or whether it is adeno. Adeno is supposed to have more of a systemic recurrence, is supposed to be more of a systemic disease, where squamous has peculiarities such as having skip metastasis and more nodal involvement, locoregional involvement. So for type 1 Siewert tumors, usually a transthoracic approach is used, either McCowan, which is more commonly practiced in the Far East, and Ivor-Lewis, which is more commonly practiced in the West. For type 3 tumors, you may not have adequate stomach to take it up into the chest or into the neck. So most of the times these patients end up undergoing a total gastrectomy, and sometimes you have to take the distal esophagus also. In type 2 is the place where the controversy exists, where we need margins on both sides. We need a conduit to reconstruct, and we don't know which stations of lymph nodes should actually be removed. So this was the first study which looked at this problem indirectly. They included, this is the famous Halsher trial, where they had transthoracic versus transthoracic esophagectomy with en bloc lymphadenectomy, 220 patients randomized, and they saw that the transhiatal approach was better for short-term outcomes and cost-effective. The R0 resection and the adequacy of lymph node resection was the same in both the arms, and also the survival was the same. There was not much difference. When they looked at the severe type 1 tumors separately, but this was a post hoc analysis, not a pre-planned analysis, the survival difference was better when the patients underwent a transthoracic esophagectomy. Severe 2 fared the same through both approaches, but in this study, we have to remember there was no neoadjuvant or systemic therapy given, and there were a lot of meta-analysis after that, but the number of randomized control trials which actually compared these two surgical approaches were quite few and small. So the meta-analysis, most of them showed that the transhiatal approach is better in terms of complication, and the survival is the same. 1 or 2 meta-analysis showed that transthoracic approach is better, but these meta-analyses are basically flawed and not applicable to the real world right now, because a lot of the trials included in these meta-analysis did not incorporate systemic therapy. So these are the 10-year results of a randomized clinical trial which was done in Japan, where they compared the left thoraco-abdominal approach with the transhiatal approach for total gastrectomy of the adenocarcinoma of the esophagogastric junction or gastric cardia. So they did total gastrectomy, and they used 2 approaches, either the thoraco-abdominal or the transhiatal. And they took patients who had 3 centimeters or less tumors, and all the patients underwent D2 lymphadenectomy, and the primary endpoint was overall survival. Again, this trial could not accrue the total number of patients. They modified the endpoint midway because the accrual was very, very long and slow, which is typical of surgical trials. Most of the surgeons will continue to do what they think is right, and they will not be ready to participate or do a trial which will be outside their comfort zone. That's why we have such few surgical trials which compare different types of surgical approaches. So only 167 patients could be accrued, out of which 66% was severe type 2 and 30% was severe type 3. So again, they saw that the left thoraco-abdominal approach had a longer operative time, had more blood loss, and had significantly major complications like pancreatic fistula, abdominal abscesses, pneumonia, anastomotic leak, empyema thoracis, and mediastinitis. But we have to remember that in this trial, which was done when they were accruing patients, was done more than 10 years ago, they were doing splenectomy as a part of D2 for all patients, which is not commonly done now. And they were also doing a total gastrectomy. So whether we can use these results to guide our surgeries now is highly debatable. But all across, when you looked at the overall 5-year survival in type 3 tumors, in type 2 tumors, everywhere the left thoraco-abdominal approach fared worse, and the transhiatal approach actually did better. So these are the basic 3 approaches that we have available in the gastroesophageal junction tumors. The right transthoracic approach, which requires 2 or 3 incisions, depending on which surgery you're planning to do. The left thoraco-abdominal approach, which requires only 1 position and 1 incision, and the transhiatal approach, which again requires 1 position and 1 incision. So what are the major differences? Differences are that the right transthoracic approach enables you to do a lymphadenectomy. Whether you do McCowan or Ivor-Lewis, you can do a lymphadenectomy and you can get margin. You can get a margin on the esophagus, and if you're doing the Ivor-Lewis, you can get a relatively good margin on the stomach side too. When you're doing a left thoraco-abdominal approach, margins are not a problem at all. The assessment of the operability of the disease also can be done in the same sitting, in the same position. You do not need to change the position. You can just cut the diaphragm, assess the disease above the diaphragm, below the diaphragm, and because the tumor is right in front of you, you can also see how your reconstruction will be. But the disadvantage with this approach is that you can only access the lower mediastinal lymph nodes, which are below the level of the inferior pulmonary vein, and the abdominal approach. It has been touted that the surgical stress associated with this thoracotomy, which is a component of the left thoracoabdominal approach, is significant. But in our experience, we have been doing this approach for the last 6 years now. We have seen that there is a learning curve to get this approach right. And after the initial 20 to 30 cases, the morbidity is actually quite less. Transhiatal approach, like my other faculty also mentioned, usually transhiatal approach will not give you a great margin on the esophagus. Also, it will not give you a good lymphadenectomy. You can only do lymphadenectomy in the abdomen, at the most a paracardiac lymphadenectomy around the GE junction. So it should be utilized only in patients who are not fit for surgery, who have other comorbidities, especially pulmonary comorbidities. When we look at lymph nodes, how we should approach them in GE junction tumors, there are not many papers, but there is a seminal paper from Seward where he showed that the true cardiac tumors have 15% lower mediastinal metastasis. So Seward type 2 will actually have lower mediastinal nodal metastasis in 15% of the cases, and this needs to be cleared. However, maximum lymph nodes metastasis are in the paracardiac region. In the upper mediastinum, they did not find that many metastases, lymph nodal metastasis. And this is a nationwide study from Japan, where they looked at esophagus predominant cancers, which included Seward type 1 mostly, and stomach predominant GE junction cancers, which included Seward type 3 mostly. And they saw that the lymph nodal metastases were maximum in the paracardiac nodal region. Less than 10%, more than 10%, sorry, had lower paraesophageal mets in Seward type 1 tumors, and the lower mediastinal mets were negligible and also the para-aortic in the Seward type 3. And the increasing T stage was proportional to the risk of lymph node metastasis. So the rate of lymph node metastasis, according to the nationwide Japanese study, was that if your length of esophageal invasion is 3 centimeters or more, you can get metastasis 10 to 15% in the upper and mediastinal lymph nodes. And you will get lower mediastinal lymph node metastasis till the region of the inferior pulmonary vein when your esophageal invasion length is more than 2 centimeters. So how should we approach the lymph nodes in GE junction tumors? When you have a Seward type 2, you can go ahead and do a standard 2-field lymphadenectomy, that is the subcarinal lymph nodes along with the abdominal lymph nodes, with either via a Ivor-Lewis or a McEwen approach. When you have Seward type 2 tumors, then you look at the length of the esophageal invasion, more than or less than 3 centimeters. And depending on the approach that you're using for Seward type 2, because Ivor-Lewis as well as left thoracoabdominal, both are applicable, both can be done in Seward type 2, you will get your lymphadenectomy. And in Seward type 3, which is, you will most likely end up needing a total gastrectomy, the incidence of lymph nodal metastasis is not very high in the mediastinum. So you could either do a transhiatal approach or a left thoracoabdominal approach if you have disease creeping up into the esophagus. So this is a study which is actually ongoing. They have enrolled 371 patients, and they are going to look at survival when you have an invasion of more than 3 centimeters or less than 3 centimeters. And if the patient, whether the patient is clinically node positive in the upper or middle mediastinum or clinically node negative, and they're going to randomize or they're going to study these patients whether with a right thoracic approach and a transhiatal approach. In a right thoracic approach, they're going to do a complete lymphadenectomy, and a transthoracic approach, transhiatal approach, they will be doing only a lower mediastinal lymph node dissection. So the long-term results are awaited, and the most other important thing is margins. So margins, again, not much literature, not too many papers, specifically only for gastroesophageal junction tumors, but this was a large retrospective study from MSKCC where there were 505 gastrectomy and esophagectomy specimens analyzed along with the survival of the patients. They saw that the R1 rates were 3%, and they looked at ex vivo and in vivo margins. That is when the margin is inside the patient's body, whereas when you resect and you take it out, we all know that esophageal margins tend to shrink. So when the margin is more than 3.8 centimeters, there is significantly improved survival. Okay, and this was seen across all type of Seward tumors, Seward type 1, 2, and 3. And this factor persisted in patients even if they had a large nodal burden. When you come to proximal margin length, another paper from Yamaguchi from Japan, they looked at ex vivo maximally stretched proximal margin. And even though they had 182 patients, out of these, majority were Sievert type 2 and 3. They did margins on frozen, and 5 of these were positive. 2 were R1 on final histology, but both were poorly differentiated and had N3 disease. And they concluded that a gross proximal margin of more than 2 centimeters was an independent prognostic factor for Sievert type 2 as well as Sievert type 3. So do not think that you can go ahead, do a total gastrectomy and not take any margin on the esophagus with a Sievert type 3 tumor. You still need a margin on the esophagus aspect. And when you increase the margin, it does not provide any further benefit in this study. And they also said that a ex vivo margin of 20 millimeters or 2 centimeters actually corresponds to an in vivo margin of 3 centimeters, that is almost 28 mm. So basically you have to aim for a 3 centimeter proximal margin on the esophagus when you're dealing with Sievert type 2 as well as 3. And what is the distal resection margin? Again, it was tough to find papers on this, especially in G junction tumors. So this is a paper from UK, from Birmingham Clinical Trials Unit, 189 esophageal and cardiac tumors, no neoadjuvant therapy to confound the results. Margin positivity was 12% in esophageal adeno and 28% for cardiac tumors. And these are distal margins, mind you. Cardiac tumors had the least distal margin, that is least negative distal margin. And if you had a gross margin of 2 centimeters, this was associated with a lesser chance of margin positivity. So surgery for gastroesophageal tumors, there is no clear consensus. There are no guidelines, but there are a few papers, and these are not very large trials. So what you have to remember is that tumor histology and location will define the approach along with the extent of lymphadenectomy. More than 3 centimeter esophageal involvement, which is going to be most of the patients that we see in India, and Sievert type 1 must consider a mediastinal nodal dissection. A gross proximal margin, so if you aim for 4 or 5, you'll get 3 centimeters, and 3 centimeters distal must be aimed for, but this may not always be possible. So if you're doing a left thoracoabdominal approach, you may not be able to get a 5 centimeter negative margin, especially in the case of a bulky tumor. Definitely this kind of margin is not possible with a transhiatal approach, but you may get these margins if you use Ivor Lewis, and especially in Sievert type 1 and 2. But in Sievert type 3, it is always a gastrectomy most of the time. So distal margins actually don't count. Now, if there is another factor that has come in after the publication of the cross trial, that is the rampant use of neoadjuvant chemoradiation. So if you have bulky tumors, which are not so like the 3 centimeter, 4 centimeter tumors, which were treated in the cross trial, these are 7 and 8 centimeter tumors, and you have given chemoradiation before you have taken these patients up for surgery, they are going to give a margin along with the radiation to the primary tumor, and a significant part of the proximal stomach may be irradiated, either by giving radiation to the primary tumor or by giving irradiation to the gastrohepatic nodes, the nodes along the left gastric artery or along the hepatic. So this will put your future conduit at risk. So this is an irradiated stomach, okay, which you're going to use for anastomosis in the neck. And when you use the stomach for anastomosis in the neck, we all know that the last 3 to 5 centimeters are not very well vascularized. So it is a not very well vascularized stomach. And along with this, it has been irradiated also, especially in the case of bulky tumors. So you may need to rethink your approach and move more towards Ivor Lewis, where you can do the anastomosis with a well vascularized part of the stomach, because you can take more margin on the stomach. You don't need it to reach the neck. You only need it to reach up to the carina or to the azygous vein. So you can throw away the part of the stomach which has been irradiated, and your anastomosis will come at the level of your gastroepiploic arcade. So the pulsations are there. The stomach is well vascularized there. So with neoadjuvant chemoradiation, you may want to think of doing Ivor Lewis approach more and more often, as it has been adopted in the West. So along with the epidemiology of the esophageal and gastroesophageal and gastric cancers changing, the surgical approaches have followed the same route. More and more people are now doing intrathoracic anastomosis, even in Japan, because they are irradiating the stomach, because they are seeing more of G junction tumors, where it is necessary to take a margin on the stomach also. So last bit of the talk, I know it has been very exhausting and exhaustive. Adjuvant therapy, no clear-cut guidelines. This was adjuvant S1, but this is not available outside of Japan. So I'll just wrap this quite fast. Also, the classic trial, only 10% of the tumors were junctional and proximal tumors, and 8 cycles of adjuvant Capox. But I don't think these people, this is widely adopted in India. Most of us give neoadjuvant treatment or perioperative treatment. Adjuvant radiation, like shown in the McDonald regimen, maximum benefit was seen in non-D2 surgery, and this was a very toxic regimen. So the other one was the critics trial. Again, here the number of gastroesophageal junction tumors was not very high, but the 5-year survival did not show any difference. And also there was the ARTIST 1 and the ARTIST 2, will also had some number of gastric proximal tumors, but again, there was not much significance in the survival. There was improvement in node positive disease in multivariate analysis. So this was the ARTIST 2, like I said, and this was just published 6 months back. Adjuvant nivolumab in resected esophageal or gastroesophageal junction tumors. A large trial of almost 800 patients randomized in 29 countries, where they were randomized to receive nivolumab versus placebo, and they actually picked the worst tumors. So these patients had undergone neoadjuvant chemoradiation. They had got a R0 resection. So they had the best, multimodality treatment. Then they had a R0. And in spite of that, when they were T3 or N1, where they had significant residual disease, either in the nodes or in the primary or both, these patients were randomized in 2:1 to get nivolumab or placebo for 1 year. They followed up the patients for almost 2 years, and they saw there was a doubling in the disease-free survival, and long-term overall survival data is awaited. This was irrespective of the PD-L1 status. But for most patients in our setup, the problem will be the financial toxicity, because it was the nivolumab was given for 1 year in the nivolumab arm. So there are certain nuances of choosing the right approach. We have to look at the patient, what he will be able to tolerate, what his choices are, what he wants, whether he wants a safe surgery, very good quality of life, even in the immediate post-op, or he is wanting to withstand something and get a longer survival, what he will be able to withstand according to his age, his comorbidities, how bad is his disease, is it a long segment which will not be covered by neoadjuvant chemoradiation, does he have upper mediastinal nodes, where you again cannot give neoadjuvant chemoradiation because you have to do a 3-field lymphadenectomy later, and the radiation fields can't be so long. And there are so many things that you have to consider, and multidisciplinary discussion is the best way to go ahead. You have to see what expertise you have available in your center and what surgery you will be able to offer. So NACT and NACT-RT, the debate is never ending. There have been meta-analysis published, there have been many studies, but finally it comes down to that both are almost equivalent, but you have to see what your patient's fitness is, what is the extent of tumor, and what surgery you're going to do later on. So if you are giving neoadjuvant chemoradiation, please discuss with your radiation oncologist how much dose will be delivered to the future conduit, not the stomach, it is the future conduit, and consider thoracic rather than a cervical anastomosis with a non-vascularized stomach, which has been radiated. And also, Ivalois is better than left thoracoabdominal or transhiatal in terms of lymph node clearance. Make sure that you do a safe surgery, you do a good job, so the patients complete the perioperative treatment. And adjuvant treatment is still in the infancy, and it is only recommended in selected patients. So with that, I would like to thank you and stop this talk here. I'd be happy to take any questions.
Thank you, ma'am. That was indeed a very comprehensive talk covering almost all aspects of the G-junction tumors. I invite all the 3 examiners now for our last segment, which is the Q&A with the experts. So we have these 5 questions, and I've directed the questions to 1 examiner each. However, the other examiners are welcome to please contribute. The first question we have is for the anastomosis technique, which is of your choice, end-to-end versus modified Collard versus semi-mechanical. Dr. Suraj sir.
Yeah, so I'm an old timer. I always do hand sewn end to side anastomosis. Old time Sabita might agree with me. I've been trained at Tata Hospital, and I'm pretty happy with the hand sewn end to side anastomosis. Although my juniors at Kolhapur Cancer Center, they are very comfortable with the staple anastomosis. But it's just a matter of choice, and I do end to side, hand to sewn anastomosis. I have my own technique of my own, which is very soon going to be published, and the leak rates and stricture rates are minimal. So it just, I think it's just a choice of the surgeon what you're comfortable with.
So what's the choice of the other surgeons on the panel?
So in the last 10 years, we have actually been moving away from the hand sewn anastomosis. A major factor for that is that we are a teaching institution, and a lot of anastomosis are done by the residents and the trainees. So doing a staple anastomosis actually standardizes the technique. So there is a standard technique, and the margin of error becomes less. Also, we get a wider anastomosis, and our stricture rates have dropped from 16% with hand sewn to 2% with staple anastomosis. So we prefer end-to-end staple anastomosis using the Oringer technique, the linear stapler.
Yeah. Dr. Parekh, your take?
Same as Dr. Samita said, stapling for all McEwan as well as for Ivor Lewis. For Ivor Lewis, earlier we were using circular staplers, but now we have switched to linear staplers, side-to-side anastomosis.
Yeah, for Ivor Lewis, we still use a circular stapler.
Our next question is how to manage oral diet in the different scenarios of a normal post-op versus a minor leak versus a major leak. Dr. Jinan.
So coming to the orals, we have to remember that when you're doing a esophagogastric anastomosis, the most important thing that will guide starting your orals is the status of your recurrent nerve, especially when you're doing a neck anastomosis. So if you think that the patient has a change in voice, then please do not rush to start the orals. Make sure you keep the right tube in situ, get a Hopkins examination done to see if there is a paralysis and if there is any phonatory gap. So these patients are at risk for aspiration. Even though they can adduct their cords and they can cough, they may still have microaspiration. So in them, it makes sense to do a functional endoscopic swallowing test to evaluate their intake of liquids versus semi-solids, and maybe start them on semi-solids first, and then slowly teach them the Chintuck maneuver, etc., and go take them onto a liquid diet. So in patients with recurrent nerve palsy, you have to remember that the oral diet will be delayed. Then when you have a minor leak or a major leak, so a major leak most of the time in 90% of the cases is treated with intervention radiology, where you have a collection in the mediastinum, you will drain the collection, and very few patients nowadays actually require disconnection. So when you're doing a disconnection, obviously you are going to do a feeding jejunostomy, but in another major leak, you keep the nasojejunal tube or your feeding gastrostomy, and you continue to give feeds. When the fluid starts clearing out, you can actually start the patient on clear water, because a little bit of clear water in the mediastinum usually does not cause that much of sepsis, especially if your patient is hemodynamically stable. You can start, and that will actually help to clear out the secretions. If you're using a sponge and you have a large sponge in the mediastinum for managing the large major leak, then again your orals will be delayed. Coming to minor leaks which are confined to the neck, usually once the purulent discharge stops coming and it is only saliva, then you can start the patient on SIPs, and slowly that leak settles with good nutritional supplementation. You almost never need to give TPN. It can all be managed by enteral feeding. So that's how we manage the oral diet in our patients. If anyone would like to comment, please go ahead.
Okay.
Madam said for normal post-operative, we have made a rule of starting with liquid diet on day 2 post-operative and semi-solid. So soft diet on day 6. So
yeah, so
all normal.
We follow sips of water on day 3 or 4, but we check the vocal cord status first in every cervical anastomosis.
And as said, whenever there is a minor leak, it is always better to give clear liquid. It will wash for all wound management, we usually wash them thoroughly. By giving clear liquid, we are washing the wound from inside. It is desirable. When patient is taking so much of saliva, why not to give clear liquid?
Perfect. Excellent points. Our third question is, a patient has come where new adjuvant chemoradiation has been delivered out elsewhere at the dose of 50 gray or sometimes 54 gray. How do we proceed in such scenarios, Dr. Parikh?
So then it depends upon the location of the disease segment. If it is in the upper thoracic esophagus, then it's a different situation. But if it is confined to lower thoracic or GE junction tumor, then certainly I will go in for surgery, and rather I would like to go in earlier before fibrosis sets in. Longer we wait, longer there is a risk of fibrosis. Another thing I have observed is that, so here we are talking about kind of salvage situation where fibrosis will be anticipated more, but with minimal invasive approach, I would like to differ from what current literature says that salvage esophagectomy has higher complication. What we have observed at our center is, in most of the cases, patient will have equivalent complications compared to neoadjuvant chemoradiation. So we are not facing more of complications compared to conventional other esophagectomies when we compare them to salvage esophagus.
I think most of the literature on salvage esophagectomies is after full dose radiation, that is 60 to 66 gray. That's why they have more of these complications, pulmonary as well as tracheobronchial and fistulas, etc. 50 gray, I think, is reasonable. It's still not that high, and you would not expect that many complications.
So even I would like to say a few things that I mean, post radiation actually it doesn't make the situation all that worse as it is anticipated otherwise. So surgery post radiation, even up to 50 grays, it doesn't make the situation as bad as it is anticipated otherwise.
Uniform answer, excellent. Our next question is, the PET CT says mildly FDG avid paraortic lymph nodes, kindly correlate clinically. Pawar sir.
No, see this now. This is a very gray area. Mildly FDG. I would like to know what is the value, but otherwise, para-aortic lymph node. You're talking about the GE junction cancer, I suppose. And if it's a mildly FDG, I would give the benefit of doubt to the patient and maybe go ahead with my original plan of action, any CT or any CTRT surgery, and maybe observe the para-aortic lymph node, which is mildly FDG evident, and take a call later on and give the benefit of doubt to the patient.
So we have attempted sometimes to get a CT guided FNA, because typically these nodes are not larger than 1.5 centimeters. They are quite small, and it's difficult to get a tissue diagnosis on them. Even when you do a tissue diagnosis, there's a 50% chance that it will be indeterminate or negative, but you still know that the lymph node is there. So we are doing a prospective study to look at these, para-aortic lymph nodes, which are in a limited location. If you can do a limited D2 resection. So we go ahead with the plan. We give the neoadjuvant treatment. We do the staging lab. We give the neoadjuvant treatment. We do the surgery. And along with the primary resection and reconstruction, we also do a para-aortic lymphadenectomy. This is only done in extremely fit patients who will withstand. It's not a complete RPLND, a retroperitoneal lymph node resection, just a para-aortic lymphadenectomy. And we have done 8 cases so far. So out of those, 2 patients actually had metastasis in those nodes, but the rest of the 6 did not have. So, it's worth knowing, and then you can go ahead and correlate with the radiology, the characteristics of the primary, and see and try and predict in which patients you should try and address these lymph nodes. Like Dr. Pawar said, it is worthwhile keeping them under surveillance if you have not addressed. We have just started doing this in the last 6 months. So if you need more close observation, maybe a scan every 3 to 4 months, and you should be in touch with your radiation oncologist also, that will they be able to irradiate this if they develop isolated lymph nodal metastasis at this time sometime in the future. So that is another point of discussion we should have.
Our last question for the day, Barrett's esophagus with high-grade dysplasia. Should we perform an esophaectomy, and when? Dr. Chivnani.
Yeah, so Barrett's esophagus is actually not one entity. There are many entities. And it also depends on the 2 things that you have to look at is the length of the dysplasia along with the grade of the dysplasia. If you have high grade dysplasia, which is limited and small, you can closely observe the patient after adequate counseling if you know that the patient will follow up, and you can keep doing bite on bite deep biopsies regularly, because if it is a small limited location, this patient can be offered limited therapy in the form of EMR, ESD. But if this is a long length Barrett's and the dysplasia is high grade, I would counsel the patient towards undergoing an esophagectomy if he is fit to undergo the procedure, because we know that in high grade dysplasia, and especially in long length, you will not have the option of giving any other alternative like concurrent chemoradiation. And also you can't give systemic therapy because it will not work on dysplasia. And these patients, long length with high grade dysplasia, are at a definite risk of developing esophageal adenocarcinoma. So you counsel them adequately on both sides and see what the patient chooses, and depending on the patient's fitness, his ability to be in regular follow-up. That is a very important thing, especially now in times of COVID. And always take consent for negative histopathology.
So
I would like to hear Dr. Pawar's thoughts on this. It's a very difficult area and a gray area.
You're muted, Dr. Pawar.
I completely agree with you, Savita. It's a very gray area, and I totally agree with you. But if it's a very high grade, I would probably go with your thoughts completely, what you said.
So that's it for the session today. I would like to thank the examiners from my side for so patiently answering all these questions and completing the discussion in a well-rounded way. I invite our advisor, Dr. Sanjay Kapoor, to kindly give his word of thanks as well.
So, Srijan, before you wind up, I just had a couple of thoughts that came during Savita's lecture. I think we have another 5 minutes to wind up. And I have some thoughts. First of all, Savita, congrats for the wonderful review of literature. It was amazing. You just mentioned that the surgery, transthoracic, left thoracoabdominal patients who are not fit can go for THE. I beg to differ with you. You know, THE patient has to be equally fit for THE or transthoracic or whatever you're doing. So you can't say the patient is less fit, so you can go for THE, and patient is more fit, so we can go for transthoracic. Or I don't agree with that. Number one.
General fitness, Dr. Pawar. What I meant is the pulmonary fitness. If you have old COX, fibrotic lungs, and COPD, then you would prefer not entering the thorax in these patients, and you could adopt when they are not fit from the pulmonary point of view. So that's the only group of patients. Earlier, we used to do around 20 THE per year. Out of the 200 esophagus that we do, it has dropped down to less than 10 in the last 2-3 years. So we are also moving away from that.
Yeah, as a general speaking, I agree with you, but there's no evidence in literature about this. Number two, you kept on mentioning about the radiation field and the conduit, the stomach tube, and the radiation to the conduit, especially in type 3 C words. But I already mentioned in our discussion earlier, the Indian stomachs are very large. And we have a very huge experience of these kind of patients at Kolhapur Cancer Center. The post-radiation problem with the conduit is negligible in Indian patients. I don't know, you're talking about maybe the Japanese, they have small stomach, the Western patients have small stomachs, but the Indian patients have huge stomachs. So the radiation problem affecting the stomach conduit and causing ischemia and anastomotic problems, I have never come across in my 25 years of experience. So that is something maybe theoretical. The post-radiation ischemic problem in stomach is unheard of in Indian patients.
So it is not theoretical. I am not discussing specifically about India. This is worldwide literature where more and more people are moving away from a cervical anastomosis to a intrathoracic anastomosis, specifically for two reasons. One is because we are giving more and more neoadjuvant chemoradiation to have a well-vascularized stomach, and second is to avoid the nerve injury. So especially in gastroesophageal junction tumors where you don't need to do a superior mediastinal nodal dissection or a neck dissection, then you can avoid these complications. That's what the literature shows.
We thank Dr. Pawar for his comments and giving his perspective on these issues as well. I invite Dr. Sanjay Kapoor, sir, what his word of
Yeah.
thanks.
Thank you, Srijan. And once again, I would like to thank everybody for making this so-called the gray issues of the gray area itself. GE junction is a comparatively newer cancer, which we have been discussing more just about a decade old. Earlier, all clubbed with lower esophagus and proximal stomach. But now we know that it's a different identity with a different prognosis, and health has to be dealt separately and with different guidelines. Initially, we just interpolated the MAGIC trial, but then subsequently with the cross trial, the FLOT and everything coming up. But still, there are a lot of gray areas because many of these trials had small numbers. Squamous cell was also mixed up with that. But beautifully conducted, both the examination plus the detailed talk by Savita. Really thankful for that to Savita. And the thanks to the participants and to the examiners. Only one comment I have, that at least the first part, since it is more for the exam going students, we must have a slide or two of the guidelines or something where we can guide those. Savita did give a lot of tips to the students where we can have a non-controversial answer which the students can give to the examiners while giving the exam, so that our debatable issues can be sorted out in clinical practice. So thank you very much, everybody, for this lovely session. And thanks especially the organizers and Srijan for coordinating. Good night.
Thank you so much, sir. The next class would be on 19th May, Thursday, same time, 7 p.m. And the topic is going to be GIST, the primer for which was given today by Dr. Devendra Parikh. I thank you all. Stay safe and have a very good night. Thank you.
Bye-bye. Good night.